Welcome to the Cardiovascular Emergencies CEN Review Part 1. This review will go along with the handout that you have available. We're going to start out by asking questions and then go over the material. First question. Patients who would not experience chest pain with acute MI include which one? 1. Patients who are less than 60 years old. Number 2, heart transplant patients. Number 3, hypocalcemia patients. Or number 4, hypokalemic patients. Let's talk about chest pain. Some of the questions you might get on the CEN could be a knowledge level. It could ask you, what does PQRST stand for? So P, provokes. What makes the pain? What causes the pain? Q, quality. What does it feel like? Is it sharp or dull? R, radiates. Does the pain radiate or does it stay in one place? S, severity. On a scale of 1 to 10, how severe is it? And time. What time did the pain start? And how long does it last if it did go away? Something else they might ask you is about stable angina versus unstable angina. So stable angina, the pain goes away with rest or with medication. Unstable angina, it does not. Another type of angina question could be Prinzmetal's angina. So this is a form of an artery spasm. So pain occurs at rest, just like the unstable angina, and ST elevation occurs with the pain only. But when pain goes away, the elevation goes away. In an actual MI, that doesn't happen. Also, who has atypical chest pain? Hopefully you know this. Diabetics, women, and elderly don't have the typical chest pain that we would see in a man. A lot of this has to do with research originally on chest pain were men only. And so the typical chest pain symptoms that you learned in school were really about men. And we have learned over time that women, diabetics, and elderly do not have the same. Let's talk a little bit about heart transplant patients. So heart transplant patients, when the heart is removed, they snip the vagus nerve. So therefore, they never get chest pain, even if they're having an acute MI. So they might have other symptoms like nausea or weakness or low blood pressure. So you have to look at other things like that. So if they do not have chest pain and they've had a heart transplant, you have other questions that you can ask. So going back to that question, patients who would not experience chest pain with acute MI include what? You got it, heart transplant recipient. Let's go to the next question. During the completion of a 12-lead EKG, the nurse identifies excessive artifact in leads 2 and lead 3. To resolve this technical difficulty, the nurse should what? Number 1, change the right electrode. Number 2, check the cable movement. Number 3, change the left electrode. And number 4, instruct the patient to momentarily hold their breath. We'll come back to this question, but just think about it. So when we're talking about the heart, we have to talk about a lot of different terminology. So contractility is the strength of contraction, how strong the heart can contract, and that gives us our ejection fraction. Stroke volume is the amount of blood ejected out of the left ventricle with each contraction. So normal adult stroke volume is 60 to 130 mils per contraction. So half a cup per contraction. Cardiac output is the amount of blood ejected from the left ventricle each minute. So normal adult has 4 to 8 liters. So you can use 5 or 6 as an average. Cardiac output can be calculated by multiplying the patient's heart rate by the stroke volume. That could be a question that you are asked in the CEN review. Mean arterial pressure, the average pressure over the entire cardiac cycle, also known as the MAP. So you might have to calculate a MAP. So D times 2, so diastolic blood pressure times 2, so the one on the bottom times 2 plus the one on top 1 time, add that number together and divide by 3, and then you can get your mean arterial pressure. Here's another way of looking at it. So cardiac output is preload and afterload. Preload and afterload are not opposites of each other. Preload is the volume that returns to the blood at the end of your diastolic blood pressure. So preload is volume. Afterload is actually the resistance. So the resistance, how much it has to work to get out of the heart. So you see that little clamp on that picture right there? It's like it's working against it. So guess what? This is also represented in your blood pressure. So the top number, your systolic blood pressure, is actually representing the volume that comes back to your heart. And the bottom number is your diastolic number, is representing the afterload, or the resistance it has to work against. So if your diastolic number is increasing, going up, then you actually have vasoconstriction. And the heart has to work harder to work against that vessel to get it out. If you have dilation, your diastolic blood pressure is going to go down, and it's easier for the blood to work out. So when you're looking at blood pressures at the bedside, look at your systolic and diastolic. That's actually your top numbers, your preload, the bottom number representing your afterload, and that will make you understand it a lot better. Vasoconstrictors and vasodilators affect your preload and afterload. So to increase your preload, you want to give them volume. To increase your afterload, vasoconstrictors like vasopressin would be some. To decrease your preload, diuretics, because the fluid would go out into their urine. Also to decrease the afterload, is vasodilators. So your ACE inhibitors, your nitro, things like that. Now let's talk about 12-lead EKG placement. So when you're doing a 12-lead EKG, you go on the fourth intercostal space. So V1, it says fourth intercostal space to the right of the sternum. Use your 4 fingers and palpate between the ribs, and you can feel them. So if you were to look at this picture, 1, 2, 3, 4, you have V1. The next one you're going to place is V2. It's the opposite side of the sternum. The next one you're going to place is actually V4. So the V4 is the 5th intercostal space mid-clavicular line. All right, so palpate, put your fingers on them. Don't just put the stickers randomly. You actually want to put them between the ribs. And then the next one you're going to place is V6, the level of, same as levels as V4 and V5, mid-axillary line, directly underneath the armpit. Okay, but you should be able to feel between those ribs. Then you're going to go back and put your V3, which is directly between V2 and V4, and then your V5, which is directly between your V4 and V6. Now you have them all on there. You also have your right arm, right leg, and left leg. Don't forget to put those on your patient before you do your 12-lead EKG. Now let's talk about 12-lead EKGs. On this picture you can see that over on the right hand side of the page you have V1, V2, V3, V4, V5, V6. Those actually go directly with the stickers you just put on the chest, in the exact same spot. You ever wondered why you have 10 stickers, but you have a 12-lead EKG? Well, the other stickers add up to be the other 6 spots, but they're not directly, not necessarily directly a sticker by themselves. So AVR is your right arm, AVL is your left arm, AVF is your left foot. Your right foot actually does not count at all, even though we put it on there. So if you had your stickers on your right arm, your left arm, your foot, I'm going to go to the next slide so you can see it. So across the top from your right arm to your left arm is lead 1. From your right arm to your left foot is lead 2. And from what's left over, your left foot to your left arm is lead 3. Now what's interesting about that is lead 2, your right arm to your foot, is exactly the same direction that your SA node, AV node, and bundle of His travel. That is why nurses always read EKGs or lead bedside monitors in lead 2, is because we're used to the method of SA to AV to bundle of His. However, cardiologists have to learn all the different rhythms in every single lead regardless. So we only learn it in lead 2. So let's look at this again. So if we have leads 1, 2, 3, and 4. So we're looking at families. So leads 1 and 2 are both sides of your septum. So they're called septal leads. Leads 3 and 4, they're on the front of your patient. So they're called anterior leads. And actually, technically, leads 1, 2, 3, and 4 are all called anterior leads. They really do go together. So those 4 are considered one family. And leads 5 and 6, those are your lateral leads. They're on the side of the patient. So 5 and 6 go together with lead 1 and AVL. So your lead 1 is across the top of your heart, and AVL is your left arm. And so those all go together. If you were to picture where those stickers are and where those axes are, then you can see how it would be the lateral side of the patient. We'll see some more pictures of that in a minute. And then you have left over is you have the inferior leads. We already talked about anterior. Inferior leads. So from the right arm to the left foot is lead 2, left foot to the left arm is lead 3. Both of those go on the bottom part of the heart as well as the foot. So that's why they go together. Here's another way to look at it. So we have V1 and V2 is septal, V3 and V4 anterior, but just remember V1, V2, V3, and V4, really they're all anterior leads. Then you have the blue group right here, the V5, V6, the 1, and the left arm. Those are all lateral leads. Then what you have left over are your inferior leads, lead 2, 3, and AVF. They all go to the bottom of the heart. So let's go back to our question. During the completion of a 12-lead EKG, the nurse identifies excessive artifact in leads 2 and 3. To resolve this technical difficulty, the nurse should what? Change the right electrode, the cable movement, the left leg electrode, or instruct the patient to momentarily hold their breath. So since that is the bottom of the heart, your answer is change the left leg electrode, because that goes together. Left leg, 2 and 3, they all go together. So you change that left leg. Let's go to our next question. A 15-lead EKG indicates a right ventricular MI. The nurse knows what administration of nitro can lead to. So don't get hung up on the 15 lead. We'll talk about 15 leads in a little bit. Let's just say it's a 12 lead, so 12 lead EKG. So if nitro, what could happen if you have a right MI? Could nitro resolve the ST elevation? Could it lead to severe hypotension? Does it lead to preservation of the right ventricular function? Or does it dissolution of the thrombus of a coronary artery? So what does dissolve the clot? What do you think will happen? So we'll cover that material in just a minute. Let's talk about MIs again. So when we were looking at earlier, lead 2, lead 3, and AVF, how it's the inferior wall. Take a look at that picture of the heart and how it looks like the inferior wall and which artery it will cover. So it's actually the RCA. Look at leads V1, V2, V3, and V4. Those are all anterior or septal, so we'll call them anterior septal walls. So see what vessel that would cover. And then when we're talking about lateral leads, the 1, the AVL, V5, and V6, those are all lateral. So this picture shows that very well. And back to the arteries. So whenever you have a right MI, you have a right coronary artery. When you have the anterior septal, then you have the left anterior descending, LAD they call it. And then if you have a lateral, then it's the left coronary artery, but usually it's the circumflex artery. The left coronary artery up there, if you can see it, if it was to have a clot, it would knock out the entire left side of the heart. So we call those the widowmaker, because they don't make it to the hospital. They usually die within minutes or seconds. without intervention. So unless it's a witnessed arrest with CPR in progress, they don't make it to us. They can make it to us if somebody sees them right away and gets them treated. Here's another way to look at these leads, and this is really important. So we have, let's go to our first set of leads. So V1, V2, V3, V4. Those are anterior leads. So what's the opposite of anterior is posterior. But since we don't put stickers on the posterior side, you don't have reciprocal leads. Reciprocal is the opposite of. But lateral is the left side of the heart, and posterior is the, inferior is the right side of the heart, because the heart is sideways. So the lateral leads, the left side of the heart, lead 1, AVL, V5, V6. The opposite of left is right. The right side of the heart is 2, 3, and AVF. They call it inferior because your heart being on the side, the right side of the heart is going down towards your feet. So this little handout shows you the different arteries and what can happen with each infarct. So the inferior, the opposite of it is the inferior being right side of the heart, opposite is the left side. So the lateral leads are the opposite. We can do a posterior MI. If we think they're having a posterior MI, we can do a 12-lead EKG and make it into a 15-lead EKG. And I'll show you that in the next slide. So let's just say they think they have a posterior MI. You can take the leads 4, 5, V4, V5, V6. Don't cross them, just put them right on the back underneath the scapula like this. So V4 becomes V7, V5 becomes V8, and V6 becomes V9. And so we would do a 12-lead EKG with those being on the back, and then you would label, you'd handwrite on the 12-lead EKG that this is a what we call a 15-lead EKG, and we're confirming the MI being posterior. Looking at this again, looking at the arteries, it's really important. So when you have a inferior, so look at the vessels on the bottom. If you had a lateral, look at the vessels on the side. So when we're interpreting our 12-lead EKG, what we're looking really for is there any elevation? So that's that middle 12-lead EKG, the middle picture right there. So elevation, ST elevation. So we're trying to, when we see the ST elevation, we're trying to prevent any cells from dying. The far right side is called infarction, also known as a Q wave. So if somebody has a Q wave, which is labeled in there, it's kind of small, that means they've either had a previous MI, and that's the dead tissue that the electrical activity had to go around, or it's already died in this particular MI. So we're looking, does it have a Q wave or does it not have a Q wave? So not all MIs have Q waves, and that's a good thing. Q waves mean dead tissue. So other things we're looking at in the very first picture is ischemia. So if you have depression or T-wave, ST depression or T-wave inversion, that is ischemia. So they're getting ready to have ST elevation. So depression is early. So also when you're looking at your 12-lead EKGs, if you have elevation, ST elevation in your inferior leads or the right side of your heart, you're going to have depression on your lateral leads, which is your left side of the heart. So the families, that's why we looked at reciprocal leads. If one is elevated, the other one will be depressed. That's another way of confirming that this is a true MI. Another way to confirm it is your enzymes. So we want to do our blood work as soon as the patient comes in, and we're looking at different enzymes. So a long time ago, all we had was CKMB. Scientists realized that there was an enzyme that was put out whenever muscles died, and that was your the enzymes. They were able to say, hey, these particular enzymes came straight from the heart, so that's your CK. So CKMB onset 2 to 4 hours. So it'd be 4 hours before their chest pain, after their chest pain, before you even seen this elevated, and it may be a whole day before it peaked. And so that really wasn't a very effective way to find out if someone's having an MI right now. So then they found out that myoglobin can also be elevated during a STEMI. So it peaks within 1 to 4 hours. Again, it'd be an hour after the chest pain started. Same with troponin. Troponin is very, very specific to cardiac only. So the heart is having a problem, so troponin is going to elevate in 4 to 8 hours and then peak tomorrow. Again, this isn't like helpful if the patient's having a STEMI right now. So we do our 12-lead EKG first, and if your 12-lead EKG has ST elevation, we will still draw the blood work, but we're not going to rely on the blood work. So here's the other way of doing it, other way of looking at it. So on the left-hand side, it goes down in errors of stages. So a person presents with chest pain or shortness of breath. The next thing we do is an EKG, or some people call it an ECG. Same thing. Here's your 3 options. If it's normal, we're just going to watch them for a while. We'll wait for the lab work to come back. If you have ST depression, we want to see, is it the beginning of a STEMI, or is it something else? Because there's lots of other things that can cause cardiac infections that can cause ST depression. Or is it ST elevation? If it's ST elevation, we are not going to wait for those lab work to come back. We're going to get the cath lab immediately. Our goal is 30 minutes or less. If it is ST depression and we do have positive enzymes, we're going to arrange for them to go to the cath lab. So that's what this chart is talking about. This is the chart that they use nationwide for all acute cardiac issues. So let's talk a little bit about signs and symptoms. So if it's your right side of your heart, and now think about it, your heart, make it like a Valentine's heart, and then turn it to where the bottom of your heart is towards your left part of your body, or your armpit, or your side of your heart. So the right side of your heart now is on the bottom. So if you have a right-sided heart attack, your heart is sitting right next to your stomach. And so the symptoms might be agitating your stomach. So therefore you might have nausea and vomiting. Okay? You're going to have low cardiac output because, again, that right side of the heart is where the SA, AV, and bundle of His run. So your brain might need some more blood. So in order to get more blood, since your cardiac output is going down, you might have jugular vein distension. It has low cardiac output. JVD is your brain dilates that vessel to try to get more blood and sugar and oxygen to it. So you could have bradycardia because it could affect that SA node, and the hypotension because of the low cardiac output. So therefore, you would not give nitro to patients with a right-sided MI. What they actually need is IV fluids. They need you to pump 500 mils to a liter in them and see if it increases their blood pressure. The left side is the opposite. So the left side, you might see lung problems. So dyspnea, they might not be able to breathe when they lay down. Their heart rate is actually going to be up high, and they might have hypertension. So they're opposite of each other. So going back to that question, a 15 lead indicates a right ventricular MI. The nurse knows that administering nitro will lead to what? Severe hypotension is the answer. I hope you got that right. Okay, here's our next question. A patient diagnosed with ST elevation myocardial infarction, also known as a STEMI, suddenly becomes bradycardic with a heart rate of 41 beats per minute, blood pressure 60/38. Skin is cool, pale, and moist. After ensuring a patent airway and adequate ventilation, the nurse should first anticipate an order for what? Application of transcutaneous pacemaker, administer atropine, set up for transvenous pacing, or administer dopamine. All right, well, stay tuned. We'll cover that material. A non-STEMI. So a non-STEMI is there's no ST elevation, but they have positive troponin. So they have ST depression, and like I said earlier, that is pooling the blood, and it may lead to ST elevation. So non-STEMI, the goal is to maintain or increase coronary blood flow, because there's not 100% occlusion, it's only partial occlusion. Decrease platelet aggregation, prevent thrombin formation, prevent microembolism, and dilate those coronary arteries. decrease oxygen demands. We want the patient to rest. We don't want them to do anything. So that's a non-STEMI. A STEMI, the goal is to restore coronary blood flow. That's our main goal right there. So the best way to do that is send them to the cath lab. So some people call it a PCI. So that's the cath lab. That's where they need to go. So fibrinolytics like TPA is 60%. So if you don't have a cath lab, TPA is your second best thing, and then send them someplace with a cath lab. So fibrinolytics, also known as clot busters. So TPA, the generic name is alteplase. So there's a few other ones. Streptokinase. The goal is to infuse within 30 minutes upon arrival, and it's not indicated for a non-STEMI. So we give them just as STEMIs. Percutaneous coronary intervention, that's PCI or the cath lab. Our goal, the nationwide goal, is to get them there within 90 minutes. St. Luke's, we try to get them there within 60, regardless whether they have a cath lab in their location or not. Let's talk some more about those clot busters. So contraindications, sometimes people cannot get them. So if they have any kind of bleeding going on, maybe they started having an MI and they fell and hit their head or hit their arm and they're bleeding, so they can't get it because they'll bleed excessively. If they have cancer, they can't get it. If we suspect an aortic aneurysm, so we cannot start TPA until you've had a chest X-ray to rule out an aneurysm. So that widens margin is what we're looking for. So any trauma, if they've had a stroke in the past or major surgery in the past 3 months, we don't get to use the TPA on them. Medications. So remember we had those goals to decrease platelet aggregation? Well, that's what aspirin is for. We also use Plavix or Brilinta. And so the other thing was prevent thrombin formation. That's what heparin is for. To dilate the coronary arteries, we use nitro. And to decrease oxygen demand is beta blockers. But also, guess what? Morphine can decrease oxygen demand. Let's talk about heart blocks. I actually like heart blocks. I don't think that they're quite so difficult. So first degree heart block is your normal sinus rhythm, except for your PR interval is greater than 0.20. That's it. So you'd have to print off a strip and measure it to see that it's greater than 0.20. People don't usually come to the ER for a first degree heart block. They don't even know they have it. Second degree heart block, they could have symptoms. So this is the one that says second degree type 1, the winky block. It says longer, longer, longer drop. Now you have a winky block. So your PR interval gets longer with each beat as you see it, and you can probably see it in this little picture right here. And then they have a P and with no QRS, so it's dropped. They drop the QRS, and then the P wave comes back and it starts all over. Even though this picture is kind of small, you still can see it. Second degree type 2 is that you have more P's than you have QRS's. And so every once in a while it just doesn't have a QRS, and there's no rhyme or reason. Third degree heart block is that you have the P's are very regular, and you can measure them out. They're exactly the same as you go along. And QRS's are very regular, but the P did not cause the QRS. I recommend that you Google heart blocks and marriage, and there's a little saying about heart blocks and marriage. I think that is my favorite one. It makes me understand it completely. If you have any questions, let me know. Bradycardia. So bradycardia, stable bradycardia, stable bradycardia means no symptoms. They don't have any symptoms, but their heart rate is less than 60. And so we're going to do a 12-lead EKG and evaluate them. Unstable, that means they have symptoms, usually severe symptoms. So we're going to treat them. So transcutaneous pacer is the choice. So American Heart Association wants electrical activity as soon as possible. Medication might take a little bit longer to work, where the transcutaneous pacing is the first choice. If you don't have a pacer available, then you can use atropine. So we can start out with 0.5 milligrams of atropine every 3 to 5 minutes. So you won't give this to somebody in a heart block or if they've had a heart transplant, atropine. So let's go back to our question. A patient diagnosed with ST elevation suddenly becomes bradycardic with a heart rate of 41, blood pressure of 60/38. Skin is cool, pale, and moist. Cool, pale, and moist means it's symptomatic. Moist is a bad sign. Your skin should be dry. After ensuring a patient's patent airway and adequate ventilation, the nurse should first anticipate an order for what? Application of transcutaneous pacer. That's right. So remember that American Heart Association wants a pacemaker before medication, if possible. I want you to know that you have plenty of practice questions available to you, and this is how you find them. So you go on to Citrix, look for Windows Explorer, go to the N drive, also known as the common drive, look for ED Topics, Series 1 through 6, and select that. You'll find 6 different classes that I've had, and you'll find the one with the cardiac. Again, if you have any questions, please let me know.